and myself, Dr. Ashish Patel, will be presenting the case, sir. So can we start, sir?
Yes, please.
Yes. Here is a patient named XYZ, age 16 years old, male child hailing from Shivajinagar, Bangalore. Informant being self and mother was admitted to us on 9th of this month and came with complaints of fever from 20 days, cough from 20 days, chest pain from 1 week, and vomiting from 1 week. History of presenting illness. Patient was apparently normal 20 days back when he complained of fever, moderate grade, intermittent type, recurring every 2 to 3 times daily, associated with evening rise of temperature, recovering partially with medication, but patient continued to feel sick even during the interfebrile period. Also associated with decreased activity from 20 days, patient prefers to be lying down on the bed all the time and is not going to school as well, and this is associated with decreased in appetite. Patient also complains of cough from 20 days, sudden onset, gradually progressive in nature, associated with sputum production, which was moderate in amount, yellowish in color, mucoid in consistency, not blood tinged, not foul smelling, and cough is present throughout the day. There was no aggravating or relieving factors. Patient then complained of chest pain mainly on the left side of the chest from 1 week, which was insidious in onset, gradually progressive over 1 week. It was sharp type of pain and aggravated on deep inspiration, on coughing, and on sleeping on the same side of the chest, and it was relieved by sleeping on the opposite side. He also complains of vomiting from 1 week, 1 to 2 episodes per day, usually after taking food containing food particles and sputum, non-projectile, non-bilious, and not blood tinged. No history of any recent weight loss, no history of pain abdomen, difficulty in passing stools, no history of headache and convulsions. And no history of any bony tenderness or deformity. Past history, no history of similar complaints in the past, no history of any previous hospitalization, no history of tuberculosis in the past. Family history, no history of tuberculosis or any chronic illness in the family members. No significant antenatal, natal, or postnatal history. Diet was 40% deficient in both calories as well as proteins. Developmental history, he was studying in 9th standard with good scholastic performance and belongs to lower middle class and overcrowding being present. So coming to the summary, this...
No, don't summarize. I think just stop sharing for a while and get to the first slide. Yeah. Now, I also want other students to kind of interact. It's not only Ashray and me talking. So would somebody other than Ashray start talking? What do you understand by this fever for 20 days and cough for 20 days? And then for a week, you have a chest pain and vomiting. Would somebody either talk or even write on the chat? And let's see what are your impressions on this history. I think, Ashray, you start talking. It appears it's between you and me now. Okay, so let's make it as informative to everyone as possible. What do you make out of this story? Now, I'll give you a clue. Forget the last week's story.
Yes,
okay,
sir.
Because 2 more symptoms have been added on only last 1 week.
Yes.
So remove that 1 week and you get 12 or 13 days. So let's talk about a 16-year-old who has come with fever and cough for last 15 or 16 days. That is all.
Yes, sir. Yes,
What
sir.
is your comment on that?
So since the fever is lasting for more than 2 weeks duration, it seems to be of some subacute illness of type of fever, sir.
Okay. See, let me first brief you on that.
Yes, sir.
Our history should possibly give us first the anatomical diagnosis, which means which system is involved and which part of the system is involved. I would call it a microanatomical diagnosis. Okay. Then having done that, you want to know what is the pathological diagnosis, which means what is the pathology I'm dealing with. And thereafter, you can guess what is the etiological diagnosis, right? So first
Yes.
tell me, with fever and cough for 15 days or 12, 13 days, where is the microanatomy of this disease?
Fever and cough with these symptoms mainly would like to think of respiratory tract infection, sir. In respiratory tract, again, we can divide it into upper and lower. But since there are no other symptoms suggestive of upper respiratory tract infection, we would like to think of more in terms of lower respiratory tract infection. And in lower respiratory tract infection, there's two symptoms. Fever associated with just the cough is present, sir. So with this, we can think both the airway can be involved as well as the lung parenchyma can be involved, sir. But there are no other symptoms at present with chief complaints where we can dissect into microanatomy of airways and the.
Okay. Why don't you think it's a cardiovascular disorder? You also get fever and cough in that.
Yes, sir, possible, sir. Fever and cough.
So it could be cardiovascular, right? Okay. Could it be any upper GI problem that he has aspirated and caused a micro aspiration, and thereafter he has come out with vomiting as well? So could it be a result of any aspiration? Okay, an upper GI problem. Suppose he has got a obstruction to the upper GI somewhere, then he's kind of bringing it out something which he could inhale into respiratory tract, cause fever and cough, and now he also says he's vomiting. What about that? So it is called as a gastroesophageal reflux. And I'm told that even adults now have a reflux disease. Okay, children of course have. So do you think it could be a reflux disease, and it's not a primary respiratory, but primary upper GI and secondary respiratory? Okay. Could it be neurological disease? He has some swallowing problem. His 9-10 nerves are possibly gone, and he has got a palatopharyngeal incoordination. He has a swallowing defect, and he has aspirated. That's why he is having fever and cough. What about that? So you could realize that same symptomatology can come through a respiratory tract primary or secondary to cardiovascular, GI, or even neurological, right? Yes. So now how do you convince me it is primary respiratory? I'm sure you people, undergraduates, are presenting, which means you are one of the brilliant ones. Okay, so I must take you to a little higher level than only accepting it's a respiratory disorder. So give a thought. Okay, I can see some more people. Would they also participate in talking, whatever possible, or those who are on the chat? Can somebody put their thoughts on the chat?
There was associated fever as well, sir. Since there was associated fever as well, we can think of infective etiology more so, sir. If it was gastroesophageal reflux disease, then fever might not have been there, sir. And cough also, there is no precipitating or relieving factors. Gastroesophageal reflux disease, it is more on lying down and more after eating their food. Those symptoms might, and symptoms of gastric irritation might also could have been present, sir.
Very good. Good thought.
Cardiovascular system, there is no other associated symptom of breathlessness or palpitation. Such things are not, chest pain, such things are not present, sir, in the child.
Very good. And therefore, very well said, cardiac problem is a cardiovascular, which means there is an increased pulmonary congestion. What is the cause? Either an left to right shunt causing an excess of pulmonary circulation, or a left-sided failure, which would come with breathlessness, and the left to right shunt would come with a child not well prior to the onset of this disease. That is a chronic problem. So this is not cardiovascular. This is not GI. Well said. Fever is not a feature, though mild fever could arise out of a chemical inflammation. And this is not neurological because the story would have first talked about neurological problem and then also said that they complicated into an aspiration. And again, fever is not a prominent feature. Therefore, it is a respiratory primary problem. Now, Akshay, you said that it is not, mostly lower respiratory. Okay, why not upper respiratory? You also get cough in an upper respiratory.
Yes, but there is no associated running nose was not there, sore throat was not there, sir.
Very
or
good.
any sinus tenderness
Excellent.
was not there, sir.
Excellent. Very good. So probably it's a lower respiratory. Okay. Now you said airway and lung parenchyma. Okay. Why both? I have either pneumonia or I have a bronchitis. I have either airway disease or I have a lung parenchymal disease. Which is this one? Is it airway or is it lung parenchyma? So far, we haven't got a chest pain. Okay.
Yes, sir.
So before the chest pain occurred, we are trying to think where we are being led to. So the point is that, therefore, always ask one question: how significant is the cough? If cough is a major symptom and is severe, then it's an airway disease. Okay. Whereas in a parenchymal disease, the cough is not a severe or a chief complaint. You have always been taught chief complaint. Out of two, which is a chief complaint? If cough is a chief complaint, yeah.
Fever first and then they spoke about cough, sir.
Fine. And therefore, you would have also said that this cough is not so severe. Then you could have also said that this cough is a wet cough. You already said brings out some secretion. Okay, yes. Sputum. And therefore, now we know that it's primary a lung parenchymal disease. Okay, airway is involved or not, we don't know at this point of time, but it's primary airway disorder. Okay. Now, tell me, does a primary primary lung parenchymal disorder, does it involve the airway? For example, you have a pneumonia, which is a primary lung parenchymal infection. Does it involve airway or it does not?
It can, so bronchopneumonia, in such cases,
absolutely
is possible. Yes, sir.
Very good. So, after all, some part of the airway is always involved, whether significant or otherwise. Okay, and that is the important point. If it is very significant, then there is a significant airway involvement, which is not an accompaniment of pneumonia. Pneumonia has a mild airway involvement, and therefore the cough is mild. But one type of pneumonia has a significant airway involvement, in which the cough is also very, very major symptom. Do you know which organism is that? That is intracellular organism like a mycoplasma. Mycoplasma yes. involves lung parenchyma and airway equally. And the fun is, it doesn't present like an acute pneumonia, but it is called a walking pneumonia or an atypical pneumonia, which means the patient is not very sick, whereas you are discussing a sick child, and therefore it is not something. So let's believe that this child has got a primary lung parenchymal infection. Let's call it a pneumonia for simplicity, and also has some airway involvement. Okay, that is yes. what it is. So this is my microanatomy. Okay, so far. Yes. We have not gone in the last week as such. Okay, now let's say what's the pathology? So pathology is obviously inflammation.
Inflammation, sir.
Okay, because there is a fever. And what's the etiology? Infection. Okay, but which infection? Bacterial, viral, tubercular, fungal, parasitic? Which infection?
Likely bacterial, sir. Since it is lasting for 20 days, more in favor of bacterial, sir.
Very good. But you know, some of the viral infection can last long. Why not viral infection?
Here's the fever, the type of fever as well. So it was low to moderate grade fever with evening rise of temperature. So viral fever, they come with high grade fever recurring every 4 to 6 hours.
Okay.
And they have all airway involvement. It is this over here. It is usually, it is more so in favor of parenchymal involvement. So widespread involvement will be there when it comes to viral.
Very good. But what's the major difference between a viral respiratory infection and a bacterial respiratory infection? The viral respiratory infection is a disseminated infection, which means it involves the upper airway, lower airway, lung parenchyma, airways, everything. Whereas the bacterial infection is a localized respiratory infection. For example, tonsillitis do not have chest problem, and a pneumonia does not have a throat problem. But in a viral infection, entire respiratory system is involved. Besides all that you said, it's going on for 14 days. It is with high fever, a very sick child. So we know it's an acute bacterial infection, right? So that much then we know. Now take it further. Now, suddenly on day 14, this child comes to you with vomiting and chest pain. What do you understand by that?
The disease is evolving, sir. It is evolving and spreading further.
All right.
Because chest pain is sharp type of pain which is aggravated on coughing and on deep inspiration. That indicates that even pleura is getting involved now, sir.
Very good. Very good. But we haven't heard which side is the pain.
Left side.
I
sir,
hope it was left side. So wonderful. Why not a pericardial pain? Why pleural pain? Okay. And why not any costochondritis? That's also chest pain.
Yes, sir. The costochondritis patient would have been able to localize.
Very good. Excellent. Excellent. What about pericardial pain?
Here it is more on deep inspiration and more on coughing, sir.
Very good. So you have already given a story. It hurts when he takes a deep breath. It hurts when he coughs. Okay.
Yes.
But therefore, it's a pleural pain. So do you think it's a complication?
Yes, sir. So the disease is evolving, so it is spreading further, sir. So complication agata, sir.
So do you think he is developing an empyema? Because we have now, to begin with, said it's likely to be pneumonia. Okay. And likely to be acute bacterial pneumonia. Okay. So now you are trying to tell me that this has further complicated into extension of pleura. So do you think it's a pleural empyema?
If it was empyema, but there would have been worsening of patient's conditions, so then you would have run hard. Because there's now infection is getting localized. Since there is foci, there would have been high grade fever, sir. So
well, his fever is persisting. That's yes. What happens in empyema. Okay, and he has a pleural complication. One of the commonest pleural complication of an acute bacterial pneumonia is empyema. So do you think this is going to be an empyema or any other kind of pleural fluid? Maybe a sympathetic effusion, not necessarily a complicated pleural effusion. And the answer is no, because in an effusion, there is no pain. Two surfaces must come. So this child has got pain. So this child has got pleuritis, but not so far pleural effusion. Okay, we don't know whether there is a small effusion, but as of now on the history, you have only pleuritis. Okay. Now, before we go further on vomiting, you said that in the history, this child had lacking in nutrition, right? His calorie intake was poor.
Yes, sir.
So which means he's a malnourished person.
Yes, sir.
So do you think that this is tuberculosis?
Yes, sir. Possible, sir.
Possible, right? Yes. So we will keep that in mind. that this is a bacterial infection, and therefore I want to know at this point of time what treatment did he receive so far? Has
So,
he
so
received?
far, yes, sir.
Yeah.
So far, he had been to 2 to 3 clinics since his symptoms did not resolve. In the first week, he had taken only paracetamol, sir. Later on, even
Okay.
antibiotics were given to him, sir.
So he has had no antibiotics.
He has had, sir. In the second week, he had antibiotics as well, sir.
Okay. All right. So the
Yes.
point is, if in the first few days, if he had no antibiotic, then he should have worsened had it been an acute bacterial infection. And the fact that he did not get worse suggests that this could be a subacute pneumonia, not an acute pneumonia. Acute pneumonia generally has fever for 2 3 days and then starts with a breathlessness. Whereas this child has not reported breathlessness. Therefore, this child must be having a subacute pneumonia, and a subacute pneumonia may be caused by not the usual acute gram positive bacterial organisms, but could be tuberculosis itself. We'll keep that open for a while. And in tuberculosis also, the lesion could extend to the pleura as much as in a bacterial infection it could. But the story of pleural involvement at the end of 2 weeks with hardly any antibiotic given in the first week suggests that this person is going worsening slowly and not acutely, and therefore we might be better off calling it as a subacute pneumonia. And then we have a etiology, either partially treated bacterial infection or an infection like a tuberculosis itself. So we'll keep it open for a while. Now tell me, vomiting means that illness has spread to the GI tract now. What have you to say to that?
Sir, or probably he has taken medication, sir. He started to take even the antibiotics he started to take. So that would have caused gastric irritation, sir. That might have led to his vomiting. And vomiting was
Agreed.
not
Agreed.
significant. Only 1 to 2 episodes of vomiting per day was there, sir.
Agreed. But it could also be a disease spreading, no? After all, the disease is in the thorax. There is a lung, there is a pleura. In the mediastinum, there is an esophagus there. So do you think that this has spread somewhere to the upper GI tract also? So no, the answer is no. It doesn't spread like that to the esophagus, but we need to know why is vomiting. So first is his cough worsening and that is causing vomiting? That's one possibility. We need to ask whether vomiting is induced by cough. Next is what you rightly said. Is it a drug that's causing gastric irritation and therefore vomiting? Or third, is he getting more sick? And if he's getting more sick, then vomiting could be a non-specific symptom of a stress, an autonomic system affection out of a stress. And he may vomit once or twice in a day, but it may not be GI. Therefore, we keep it open. We are not going to push a lot of importance to this vomiting at this stage. And we will say that either it is cough induced or drug induced or an evidence of a stress, and the child is gradually worsening. That is all that we know. So far, your impression, would you summarize now what you think must be wrong with this person at the end of the history?
At the end of the history, it looks
sir, if you would allow me, sir, I have a doubt. Hello?
Yes.
Yes, sir. So why can't it be protracted bacterial bronchitis?
Pardon, I can't get you. Your voice is breaking.
So why can't it be PBB, sir? Protracted bacterial bronchitis.
Yeah. Now, protracted bacterial bronchitis does not present with persistent fever. It presents it with persistent cough.
Yes, sir.
And therefore it's not over. But good thought. Yes. We started saying that if the cough is not a major symptom, then we have a lung parenchymal disease in which also airway is involved. Therefore, Akshay, the point is every time you have a cough, please make a note how significant or severe is this cough. Severe the cough, airway is the primary involvement, upper or lower, then dry or wet cough makes it easy to understand. But a good thought, it is also a bacterial infection and it is protracted. It is so subacute that fever is not a feature and almost they look like an asthmatic cough. The difference is asthma has a nocturnal variable wheeze and cough, whereas protracted bacterial bronchitis has no variable cough. It is just same all the time. But good thought. Good that you brought this point. All right. So how do you summarize
Yes,
the
sir. Thank you,
history
sir.
now? Yeah. How do you summarize the history?
So by the end of this, we would think that child is suffering from a subacute to chronic infection involving the respiratory tract, mainly the lower respiratory tract involving parenchyma more than the airway, probably of infective etiology, and it can be mostly tuberculosis.
Very good. Good. Let's see now what examination findings do you have. Yeah, just read the summary. Yeah, good.
16-year-old boy who presented to us with complaints of fever from 20 days, cough with expectoration from 20 days, chest pain from 1 week, which was sharp type, associated with the patient being sick, not able to do his routine activities, decreased appetite as well, belonging to lower middle socioeconomic section with overcrowding being present at home, with dietary deficiency of 40% calories and proteins. With this, would like to consider that patient is suffering from a chronic systemic illness involving the lung parenchyma along with the pleura due to infective etiology, probably tuberculosis.
Very good. Excellent. Fine. Tell us the examination finding.
On examination, general physical examination, patient was lying down comfortably. He was conscious and cooperative. Vitals, pulse rate of 81 beats per minute, good volume. All central and peripheral pulses were felt. Respiratory rate of 19 cycles per minute. Temperature was 98.8 degree Fahrenheit and saturation was 98% under room air. BP was 110 by 70 mmHg. Anthropometry.
Just go back to that slide and tell me what do you interpret out of this?
Vitals were stable, sir. It was all within the.
Now look at that. You are talking about 3 weeks of illness in a malnourished person, chronic illness, and he has got such a poor calorie intake. But even then, he's very stable hemodynamically. Does that correlate correctly?
So since it is a subacute to chronic illness, it is possible that.
Very good. So what it means is it's a slowly progressive chronic disease. Slowly progressive chronic disease, which is neither causing significant tachycardia or a tachypnea, which also means that the fever is not high, at least when you examine this person.
Yes.
And which suggests strongly that you are talking about a slowly progressive chronic infective illness, almost meaning that you are on TB only. Okay.
Yes.
How each of these findings can make you add some more vital information in supportive of your probable thinking of a diagnosis of TB, right? Go ahead.
Yes. Anthropometry-wise, severe thinness was present, sir. BMI of 15.4 was there. Head-to-toe examination, no pallor, icterus cyanosis, clubbing or lymphadenopathy was present. No cutaneous markers of tuberculosis was also present, sir.
Fine. What are cutaneous markers of tuberculosis?
The cutaneous markers of tuberculosis can be lupus vulgaris can be there, scrofulloderma can be there, or on eye examination, phylectin is possible.
Okay. Do you know what is erythema nodosum?
Erythema nodosum can be possible.
Yes. What happens in the eye that suggests possible TB? Flictin. Frictinular conjunctivitis. So you might look for all that, but yes, those are the indirect markers of a probable tuberculosis, but not necessarily only tuberculosis, right? Okay,
Yes, sir.
go ahead.
So, respiratory system inspection, trachea appears to be central in position. Prominent lower rib cages are seen. Bilateral chest movements are symmetrical. There is bilateral supraclavicular and infraclavicular hollowing is present, probably because of wasting. On palpation, trachea is central in position. Chest expands symmetrically on both sides. On measurement, chest centimeter of 68 centimeter is present on expiration and 70 centimeter is present on inspiration. So chest expansion is only 2 centimeters. Sir. Right and left hemithorax, there is no difference. On doing vocal femmitus, there is reduced vocal femmitus was present in left infraaxillary area. On percussion, there was dull note present in the left infraaxillary area. On auscultation, bilateral normal vesicular breath sounds were present, but again air entry was decreased on left mammary and infraaxillary region, and vocal resonance was decreased in the left infraaxillary regions.
Go ahead.
Other systems, there was no significant findings in other systems.
Okay, now tell me the interpretation of your chest findings. Okay.
So one is the chest expansion is reduced, sir. Again, likely possible of pleural etiologies is not able to take do deep inspiration. Next is there is reduced vocal femmitus on the left side with dull note on percussion, and again decreased to absent air entry in the left infraaxillary region, sir. So probably there is pleural effusion in the left lower lobe is possible, sir.
So which means that there is no lung parenchymal disease.
Sir,
we started talking big about lung parenchymal disease, maybe airway, and then complicated into pleural. But now we have only a pleural disease. How can that be?
Yes, sir. But clinically, we could not pick up, sir, on auscultation.
All right. Now, for a pleural effusion, there is neither a mediastinal shift nor any breathlessness. Then why do you call it a pleural effusion? There is no pleural effusion.
Minimal amount of pleural effusion might have been there, sir.
But there may not be also, no? You are right. You are presuming there is a pleural effusion, so you convince me it must be small. Yes, but sir, it may not be at all, no?
But as per the clinical findings...
Good. So tell me, why not only the collapse? In a collapse of the parenchyma, okay, you get same findings that you talked, dullness and decreased vocal resonance.
That time lung, there would have been shift to the same.
So we started saying that's a lung parenchymal disease. So let me say it's only a collapse. Why bring in pleural and pleural effusion? And we said that in pleural effusion, there is no pain. Whereas this child has got a chest pain. So why pleural effusion?
Might be pleuritis is leading into pleural effusion now, sir. It is again evolving, sir. Might be in next few days, pleuritis might disappear and pleural effusion might come into the picture, sir.
Okay. Now, let me put you a question in a different way. What is the major difference between a lung parenchymal lesion and a pleural lesion? Okay. Both may have similar finding. I told you, a collapse has similar finding. But what is the major difference? The major difference is a lung parenchymal disease has signs which are called in lobar distribution. What does it mean? Either upper lobe is involved, middle lobe is involved, or lower lobe is involved. And on the left side, upper lobe is involved, lingula is involved, or a lower lobe is involved. But in pleural disease, it is not any particular lobar distribution, and therefore we call it a non-lobar distribution, which means it could be anywhere. Now, as this is possibly not fitting into any lobar distribution, and there you use your knowledge of a surface anatomy of the lung. And on the right side, you have an upper lobe, anteriorly upper part, and anteriorly lower part is the middle lobe,
Middle lobe,
and posteriorly is the lower lobe.
lower lobe.
On the left side, upper lobe is anteriorly and lower lobe is posteriorly. These signs are largely infraaxillary. They are not fitting in either of the two. Therefore, there could be a small segmental involvement or a pleural involvement. And you would have said that there is a pleural involvement, maybe pleuritis, but we are not sure whether there is a small effusion which is not causing any mediastinal shift or any obvious breathlessness. But the major difference is between pleural distribution and lobar distribution. But one more fact I want to teach you at this point of time, that tell me what are the signs of a pneumonia on chest examination? You have an impaired note? Yes.
Yes, there will be consolidation, sir. So there will be impaired note.
So what are the other?
There will be bronchial breath sounds will be present. There will be impaired note, but on vocal resonance, it will be, since there is consolidation, there will be increased vocal resonance, sir.
Very good. So there could be a bronchial breathing and there could be an increased VR and TVF, right? In a pleural disease, that won't happen, but the impairment will be there. Now I'll tell you a little catch on this. In tuberculous pneumonia, how does the tuberculous pneumonia starts pathologically? It starts as a primary complex, which means it starts as the mediastinal lymph node, a hilar lymph node. And when this hilar lymph node goes on increasing and the disease spreads to the lung, what happens? You develop a pneumonia, but there is also a lymph node there. Now that lymph node could press the bronchus that supplies the pneumonic area, and therefore there is no bronchial breathing, there is no increased VR. In fact, there is decreased VR, and pathologists called it as a collapse consolidation. So in tuberculosis, the pathology is collapse consolidation. In a staphylococcal or a streptococcal pneumonia, the pathology is only consolidation. So this could be a collapse consolidation, and in a collapse consolidation, because of the collapse, you do not get signs of consolidation like bronchial breathing or increased VR or TVF. And it sounds like a pleural disease. That's why we are still open on this, whether there is a lung lesion demonstrable or only a pleural lesion. But one thing is certain, that if there is a pleural lesion, it is there. It must be secondary to a lung lesion. And therefore, we have to have a lung lesion in this child, whether we can demonstrate it or not. But the point I want to make you is that collapse consolidation looks almost like an effusion. And if this child has persistent pleural pain, then I may not much think about a pleural effusion, but think about pleuritis, which has, of course, a small effusion there, but not clinically much visible, right? So that's where it is. And so I think it appears that your thought process to begin with, that this must have been a subacute or a chronic infection slowly progressing in a person who is nutritionally deprived, suggests a possible tuberculosis, right? Just before we go further on investigation, etc., do you think this could be an HIV? Because tuberculosis and HIV go together.
And adolescent age group as well, sir.
So, do you have any story suggestive of a probable HIV?
But there is no high risk behavior in this child, sir.
So, what kind of history do you ask to suggest a probable HIV infection in this person?
then we'll have to go and ask into the personal history of the child, sir. Whether there
Very
is
good.
IV,
Very good.
IV drug abuse or any multiple sexual intercourse is present. So all this history will become important, sir. Or we'll have to ask the mother as to how has his behavior been offset, whether any violent behavior is present, whether he's mingling too much with his friends, is he returning home on time? All this other personal history becomes important, sir.
Very good. Very good. Could it be that the mother has transmitted this HIV to him 16 years ago? And his behavior is fine.
He would have presented much earlier, and that symptoms would have been present in the mother as well, sir.
Very good. Very good. And his mother also would have been sick by now. Okay. Yes, and therefore, you already told us that there is no past history of repeated infections. And therefore, with his normal behavior, no drug user, okay, etc., we possibly consider this as a non-HIV problem. But consider always when you are talking about TB in a young adult or so, you have to consider HIV and TB together because each one of them makes it the other one worst. TB makes HIV worse and HIV makes TB worse. And therefore, we need to look at that. Fine. Now, what investigations have you planned?
Sir, investigations.
Just before that, rightly you have put it as pleural effusion. Let me dwell a little more at this point of time. One who has got a good immunity develops pleural effusion. Okay. Yes. And this person seems to have not so good an immunity. Therefore, either he may produce a very minimal pleural effusion or there may not be a pleural effusion. But had it been a very healthy, normal, well-built, well-nourished 16-year-old, he would have presented with a large effusion, with coming to you with breathlessness. This child has not done that because he is immunologically weak, and therefore a pleural effusion is a classical disease of a good immunity. And this child has obviously a little poor immunity, and if so, then his pleural effusion must be very mild and not major. And that is our impression, right? Good. Yes. Go ahead. Go ahead.
Next investigation, what we would like to do is from RNT or from the NTP point of view, if we are suspecting tuberculosis, first we'll have to get the chest X-ray, sir. And if chest X-ray is suggestive of any changes, then we'll do CB-NAT. And we can plan our routine investigations of CBC, RFT, LFT, and electrolytes, sir. So these are the investigations we did and this child underwent.
Very good. Now, how will you get a specimen for CB-NAT?
For him, since he was able to expectorate his sputum, it was easy only since we got his sputum sample only, sir.
Fine. And how would you pick up a sample in a small child?
So in a small child, if he is very small, then we'll have to try gastric lavage, sir. If he is big enough, then induced this thing is possible, sir.
Very good. Excellent. Now tell me the investigations.
Investigation HB was 11.6, total count of 17,600 with 68% neutrophilic predominance. Platelet was 4.7 lakhs. ESR was raised at 48.
So this must be bacterial infection, not TB. You have a neutrophilic leukocytosis. You agree? It's almost 1,800. That's normally 18,000. Normally considered to be anything beyond that is the acute bacterial infection. You have a predominant polymorphs. Okay. So it must be an acute bacterial infection, not TB. What's your comment?
There might have been underlying TB, but if this is the, so we can think of superadded infection, sir. But still, TB is the primary pathology, sir.
All right. Now that brings to a very pertinent question. Who gets superadded infection? Who should get superadded infection? Anyone can get superadded infection.
If there is any cavity lesion or something present, that cavity can get superadded
Very good. So what you are trying to say is that if the secretions are retained somewhere, then you get superadded infection. What are the example? Sinusitis, chronic, retained secretions. Bronchiectasis, retained secretions. Right? Cavity, retained secretions. So that's one cause. This child doesn't have. What are the other causes of superadded infection? Immunocompromised child. Okay. Now this child is not so immunocompromised. Well, he is a little bit low in immunity, but we won't call him immunocompromised. So that's not likely to be the cause. And therefore, possibly the conclusion is in TB, any kind of CBC is acceptable. It depends on how severe is the inflammation. After all, there is the destruction of the tissue, there is an inflammation, and the inflammation is throwing up some polymononuclear response, not major. Therefore, what have you learned? CBC in TB can be anything. Can be a low count, a normal count, a high count, a lymphocyte, a poly, whatever. It does not make any difference at all. And I think that's the way you will not worry about this little neutrophilic preponderance, right? Go ahead.
RFT electrolytes we got it done to start, since we were planning to starting with ATT baseline levels we wanted to.
Tell me, why did you do that? You have a TB in the lung. Now, why have you to do an RFT? Where is the kidney involved? Or you're looking at a TB spread to the kidney?
No, sir.
Then why are you doing it? Yeah, point that many times now in our hospital setting, somebody who has got a prolonged fever, baseline investigation includes LFT, RFT, electrolyte, all that. But I don't think it's very rational. I don't want to see RFT in this child. Okay, do I want to see an LFT in this child?
Yes, sir.
Why?
Because we are starting on ATT, all the ATT is metabolized by the liver. We would like to see an LFT, sir.
But does he have any liver disease just now?
No, sir. But if we are if he comes after 1 week with any
drug-induced liver injury, even if you don't do LFT now and afterwards he develops bilirubin, I know he has a drug toxicity. Why do I have a baseline normal? Okay, no, your answer is a malnourishment is a liver disease. Liver is not normal in malnutrition. And therefore, you are right, you do a liver function test. Okay, but baseline reading is not for normal to see whether there is already a little low albumin, okay, or a little raised enzymes. And something that would bother me when I start my anti-TB treatment, and I would be a little more careful, or might even start with a little lower dose if you have already got a little low albumin and a little raised AST, ALT, but this cell doesn't have. So possibly we will not worry a great deal about that, right? Okay, go ahead. But now CRP is normal, right?
CRP is raised, sir.
Raised, both raised. Okay, all right, good. Okay, go ahead.
Manto done was negative, sir. There was no induration.
So why did you do Manto test?
So that would have come out as a supportive evidence for us, sir.
Okay, so now what has happened is, now the recommendations are tuberculin test is not done for diagnosis of tuberculous disease. It is only required to diagnose a latent infection in TB. Okay, but this cell is negative, which means he has no TB at all.
No,
so diagnosis is wrong.
Since we are thinking of malnourishment, his immune system might have been low, sir. That's why body didn't mount a response.
Fine. So the point I'm making is now Manto test is reserved only for diagnosing latent infection and not a manifest disease, right? So that's beside. Okay, sputum analysis.
25 epithelial cells with 25 pus cells, gram-positive cocci in single pairs and clusters. KOH was negative for fungal elements, sir.
So that means you have a bacteria there, gram-positive cocci. Where is TB? There is no TB.
That could have been local flora also, sir, when he was getting out his...
Excellent. So any damaged tissue has multiple organisms there of no concern. And you are lucky that you have a CB-net already positive with rifampicin sensitive. Okay, fine. So what is optional? What did you say? Optional evaluation?
Sir, ophthal evaluation.
Ophthal, yes, that's all right. Why did you do ophthal evaluation?
Sir, one is we are starting ethambutol. Other one was to look for again tuberculosis only. Any tuberculitis or something was present, sir.
Okay. Actually, you want to check for any fundus for a neurotuberculosis, certainly, but you don't need an ophthalmic examination routinely. At one time, it was thought that ethambutol could cause optic atrophy, but today that is all given up in a dosage that we are. And I think ophthalmic evaluation, to my mind, may not be necessary. Okay, yeah, go ahead. What next?
So this was the X-ray, sir.
Very good. So how do you read this X-ray?
This is X-ray, sir. Plain X-ray PA view, sir. Trachea appears to be central, sir. Cardiac borders appears to be normal. Diaphragm and subdiaphragmatic regions are also normal. Coming to the lungs, bilateral upper zone appears to be normal. Mid zone and left side, in the lower zone, there is a thin cavitary lesion that is present, sir. And surrounding the cavitary lesion, there also appears to be some amount of homogeneous opacity is present. So likely, again, there might be some amount of consolidation as well. And there is blunting of left costophrenic angle, sir. So some amount of pleural fluid.
Very good. Very good. Very good. Because you have a homogeneous, dense, small opacity with patchy lesion. So obviously there is a lung lesion and there is also pleural lesion. It could be pleuritis or it could be just a small effusion. Yes, you are right. You said it's a PA view, right? You said chest PA view. Why did you call it PA view? Why not AP view? So in PA view, you go by the scapula. In AP view, the scapula is out. In a PA view, the scapula is almost over there. That's why this is a PA view, right? Okay.
Yes.
Now, do you want to put in a needle and take out the fluid?
No, sir. Since we are thinking of pleural effusion, tuberculosis, even if pleural effusion is present, that will be as part of hypersensitivity reaction, sir. So,
fine. So you don't want anything. Do you want to pick up a CT scan?
So CT scan, if we were thinking of any lymph node involvement, then CT scan might have been helpful, sir. But here, as from chest X-ray, lymph node doesn't appear to be involved, sir. Or any other hidden lesions also we are not thinking of, and that is not going to affect our treatment. So
very, very good. Very good. So you don't need anything more. What other tests would you do? It's a tricky question. Just give a correct thought. What other tests would you do? Would you look at the other family members?
Other family members we will screen.
Now, which other family members you would pick up, or you will get everybody's chest X-ray?
Sir, any symptomatic family members will check for. Then if it's
Very good.
coming to his siblings, less than 5 years means we again check for everyone. More than 5 years means again symptomatic siblings will again test for, sir.
Very good. So if there is any sibling under 5 or above 5, you might do their tuberculin test to find out whether they have an infection already without a disease. They are asymptomatic. So that's one place where you could have run a man-tooth test. And if it's under 5 years, you might have even to consider treating them for a prophylactic therapy. You know today that the government of India has now pushed on a tuberculosis eradication program. not tuberculosis control program, tuberculosis eradication program. And that eradication problem wants us to pick up latent infections, which can be treated at that point of time for those who risk into developing disease thereafter. And that is largely under 5 years or any other comorbid condition. And I think that is a part of testing in this child, because having got this child, we need to find out from whom he got it. Of course, he could have got it from anybody other than family members, but he is also at risk of family members. In adults, old age, those who have diabetes, those who have a chronic respiratory disorder, they are all at risk of getting TB. And therefore, you would have looked at their tuberculin status as well, right? Now, how would you treat this child?
So this child, we start with intensive phase and continuous phase, sir. So 2 months of intensive phase, HRE, followed by continuous phase, HRE, for 4 months, sir.
Okay. So do you think it's the same regime for all types of tuberculosis?
Sir, if it is spinal tuberculosis and if there is meningeal tuberculosis and bone involvement, then we continue for 8 to 10 months, sir.
Very good. Fine. Now, suppose this child improves after a month or two. Okay. How do you know he has improved?
Sir, as per the recent guidelines, if he is improving, then after 2 months, nothing is needed, sir. Only at the end of 6 months, we'll get a repeat chest X-ray. But if he is not improved, then after 2 months, then we'll have, if there is no relieving symptom at all in 1 month, then we'll have to think of repeating chest X-ray, and we'll have to think of drug-resistant tuberculosis, sir.
Very good. Now, I'll give you a third situation. You rightly told me what to do if he's improved and what to do if he has not improved. Now, suppose he improves after 6 weeks or whatever, and then after another 4 weeks, he starts deteriorating. Now, what do you do? You get the question. Initial improvement, his appetite came up, his fever disappeared, his weight improved, his cough got better. And after another month of remaining reasonably under control, he starts all over again with fever, cough, the same symptoms that he came with.
Then we'll have to first check for the compliance of the medication, sir.
So does it mean it is a drug resistance? Or it's some other complication?
Or it can be secondary to hypersensitivity. Upgrading reactions also are possible, sir.
See, hypersensitivity reaction typically in the form of only 2 or 3 things. One, a pleural effusion or a lymph node enlargement. Or in CNS, in terms of meningitis. But otherwise, in a lung, there has to be either an effusion or a lymph node. But he has neither of that. What I'm trying to tell you is that out of a 4 drugs that you started with, he started getting better after 2 months, and you therefore said you are fine and we will now drop pyrazinamide. And by now, he starts developing all over again. This means he has still a possibility of a drug resistance. Out of 4 drugs, if 2 drugs were working, they started killing those bacteria, tubercle bacteria, which were sensitive to them. And thereafter, that caused some improvement. But after that, what remained in his system was only the drug-resistant bacteria. This is how the selection happens, and it is not rare to see a drug resistance patient improving for a while, but deteriorating thereafter. And that is because all sensitive strains are destroyed and all resistant strains are now multiplying galore. And therefore, again, the burden of illness starts coming. So the drug resistance comes in 2 ways. One, either a patient doesn't improve at all, which means majority of the 4 drugs that are not working, or some drugs are working, some are not working, giving you a false impression of a initial improvement and then deterioration. So keep in mind that, and that's why a continued follow-up, okay, right through, and you are right to say at the end of 6 months. Now, before you stop treatment, would you like to do some tests?
Sir, at the end of 6 months, if his symptoms have subsided, then only chest X-rays recommended, sir.
Fine. There is no need.
There
Okay.
is no need,
If,
sir.
if everything, but suppose the parents insisted on it and an X-ray still shows some lesion, then what would you do?
Then
You get my question. Patient
Yes,
is fine. He has improved. Right from last 4 months, he has been absolutely all right. But
if there has been adequate weight gain, if there is improvement in symptoms, then that means that the lung pathology needs time to heal, sir. So we can wait, sir, that time.
parents are not happy. They said, sir, X-ray is not improved. And therefore, they want you to do something more. So can X-ray not improve, but the patient improves?
Yes, sir. Possible, sir.
Because your answer is the damage sometimes may take a long time to recover, or at some time, if there is a fibrosis developing, then it may never resolve completely. But there would be a radiological shadow, but it will be not an active disease. How would you confirm that? One, because he has no symptoms at all, and another, that his ESR has come back to normal and everything looks all right. Okay, so that is the way. Lastly, what is the prognosis of this child? He will do well?
Yes, sir. If he's responding to treatment, then he will do well, sir.
Very good. And do you think that once he is cured, he will never get TB again?
No, sir. Again, relapse is possible, sir. Again, whenever if at all his body again goes through any stressful situation where his immunity is affected, then again the TB might flare up again, sir.
But for that, he has to come in contact with TB again, right? So can his own lung lesion never completely disappear?
Yes, sir. That is possible, sir. Latent TB can be present in the lymph node or in this thing itself, sir.
So the point is, in TB, the last bacteria is never killed. There is always some bacteria left behind. And if that is so, there is always a small chance of a reactivation. And only his good health and good immune system protects him from that reactivation. But you have some bacteria which are remaining. And why do they remain like that? You have 4 drugs today, no?
Yes.
Then why some bacteria remain? There is not a single cured child who does not have even a single bacterium there. Why is that? And the reason is all 4 drugs act only on actively multiplying bacteria.
Yes.
Some rapidly multiplying bacteria, some slowly multiplying bacteria, some intracellular multiplying bacteria like a pyrazinamide, but none of the known anti-TB drugs kill the dormant bacteria. They appear to be sleeping, they appear to be dormant, and no drug works on them, and they remain forever, waiting for a chance to reactivate if your immune system goes down. So point is, there is always a chance of a reactivation. It's not a failure of your treatment, right?